Okay, let's try and picture this. Imagine your heart muscle, that incredibly hardworking part of you, starting to lose its stretchiness. It gets stiff, finds it hard to relax and fill up with blood properly. That's really the heart of what we're exploring today. Restrictive cardiomyopathy. We're going to really unpack the key bits from the revision notes you've got there, the aim, to give you a clear, sort of high-yield overview. What it is, why it happens, what it means, but keeping it focused. Perfect if you need the crucial info without getting totally swamped in detail.
Exactly. Let's get straight into it. So restrictive cardiomyopathy, fundamentally, it's about that heart muscle stiffening up. And that stiffness really messes with its ability to relax properly between beats, which affects how it fills with blood, diastolic dysfunction, basically. What's quite distinctive, though, is that even with the stiffness, the main pumping chamber, the left ventricle, usually stays a normal size. And its squeezing power, the systolic function, that's often preserved, too, surprisingly.
So it's not like a weak, floppy heart that can't pump.
Right. It can pump. Often quite well, initially.
Yeah.
The problem is more like trying to fill up a really rigid bottle. Getting enough blood in becomes the challenge because it won't expand easily. And that difference is pretty critical when you think about how it's different from other cardiomyopathies and how we might treat it.
Okay. The stiff heart, normal size, normal squeeze, the poor filling.
Yeah.
What happens next? What are the consequences of that poor filling?
Well, because the ventricle can't fill properly, blood backs up. Pressure starts to build in the chamber before it, the left atrium. Over time, this high pressure can actually stretch out the left atrium, enlarge it. We call that atrial dilatation. And importantly, it also increases the risk of developing irregular heart rhythms, arrhythmias. And just to put it in context, cardiomyopathy in general is a known cause of sudden death, sometimes even in younger people. So understanding these types is really vital.
Yeah, absolutely. You mentioned other types. Just quickly, how does restrictive cardiomyopathy sort of fit in comparison?
Good question. So very broadly, you've got hypertrophic cardiomyopathy, where the muscle is thickened, dilated cardiomyopathy, where the heart is enlarged and weakened, the pump is failing, arrhythmogenic cardiomyopathy, which primarily affects the heart's electrical system. And then restrictive is, well, it's distinct because the main issue isn't thickness or weakness, it's this lack of compliance. Stiffness leading to poor filling.
Stiffness, that seems to be the absolute key word here. What actually causes this stiffness? What are the underlying sort of culprits?
Yeah, stiffness is key. And the causes, well, they're quite varied. Sometimes, frustratingly, we investigate thoroughly and still can't find a specific reason. That's what we call idiopathic. Then there's a condition called endomyocardial fibrosis, which seems linked to something called Loeffler's syndrome, involving high eosinophil counts. But probably the most common category, certainly in Western countries, is what we call infiltrative myocardial disease.
Infiltrative.
Yeah.
Like something getting into the muscle.
Exactly. Abnormal substances literally infiltrate or deposit within the heart muscle tissue. They get in the way, make it stiff, less pliable. Amyloidosis is the most frequent one we see in this group, abnormal proteins depositing. Sarcoidosis, an inflammatory condition, can also cause infiltration with granulomas.
Okay, amyloid and sarcoid. What else?
Then you have storage diseases. The body isn't handling certain substances correctly, and they build up in the heart, like hemochromatosis. That's iron infiltration. Think like hemoglobin relating to iron. That can be a helpful link. Fabry disease is another, involving glycolipid storage. And Pompe's and Cory's diseases involve glycogen storage. And finally, radiation therapy, particularly to the chest area, can sometimes cause fibrosis and lead to restrictive cardiomyopathy later on.
Wow, okay, that's quite a list. Amyloid, sarcoid, storage diseases like hemochromatosis, radiation. Are there particular things that make someone more likely to develop it? Risk factors.
Age is definitely one. It tends to be diagnosed more often in older adults. Having a family history of any kind of cardiomyopathy or even sudden cardiac death in the family might raise suspicion or risk. And logically, if someone already has a diagnosis of amyloidosis or sarcoidosis affecting other parts of their body, they're at a higher risk of it affecting the heart in this way.
Makes sense. So stepping back to the mechanism, the pathophysiology, the heart stiffens, can't relax, can't fill. Can you just walk us through that chain reaction inside the heart again?
Sure. So fundamentally, that stiff muscle just loses its ability to relax and lengthen properly during diastole. That's the filling phase. This poor relaxation is often because of those infiltrative substances like amyloid we mentioned, or maybe scar tissue, fibrosis, replacing healthy muscle. Because the ventricles can't expand fully, they simply can't take in a normal volume of blood. Reduced filling volume then directly leads to a reduced stroke volume, less blood pumped out with each beat. And that ultimately results in reduced cardiac output overall. The body isn't getting the blood flow it needs.
Right. And when a doctor sees a patient with symptoms suggesting this poor filling, what else might be on their mind? What conditions look similar? The differential diagnosis.
Ah, yes, the differential. This is really important. The absolute classic condition to differentiate it from is constrictive pericarditis. In constrictive pericarditis, it's not the heart muscle itself that's the main problem, but the pericardium, the sac around the heart, becomes thick, scarred, and rigid. It physically constricts the heart, preventing it from filling properly. So similar symptoms, impaired filling, but a different underlying structure causing it.
How do you tell them apart then?
It can be tricky. Imaging is key. Cardiac MRI, as we'll likely discuss, is particularly good at looking at both the heart muscle and the pericardium. Also, measuring pressures inside the heart during cardiac catheterization can show characteristic patterns that help distinguish between the two. Other things to consider, though less common mimics, could be severe hypertrophic cardiomyopathy. Sometimes cardiac amyloidosis presents in ways that need careful distinction, endomyocardial fibrosis again, and even things like cancer spreading to the heart, metastases, carcinoid heart disease, or the late effects of radiation. Oh, and cardiac tamponade fluid buildup in the pericardial sac squeezing the heart can present with some similar constrictive features acutely.
Got it. So constrictive pericarditis is the big one to rule out. Now, how common is restrictive cardiomyopathy? Is this something doctors see frequently?
Actually, no. It's considered the least common of the major cardiomyopathy types. Maybe around 5% of all cardiomyopathies, give or take. We do tend to see it more in older people. It seems to affect males and females pretty similarly overall. Although, interestingly, the idiopathic form, the one without a clear cause, might be a bit more common in older women. Despite being rare, it's significant because it can be severe enough to lead to someone needing a heart transplant. It doesn't usually have a strong familial inheritance pattern, unlike some other cardiomyopathies. And geographically, it's known to be more prevalent in certain areas, like parts of tropical Africa, often related to that endomyocardial fibrosis we mentioned earlier.
Okay, rare, older adults mostly, but can be serious. What would actually bring someone to the doctor? What are the typical symptoms and signs?
Yeah, the symptoms are often related to that reduced cardiac output and the backup of pressure. So things like feeling really tired, weakness, fatigue, shortness of breath dysmorphia, especially with exertion, is very common. Some people might experience chest discomfort or even pain. On examination, a doctor might hear heart murmurs, maybe from valves becoming a bit leaky due to the distorted pressures or chamber sizes. A loud third heart sound, S3, can sometimes be heard that relates to the rapid, abrupt filling in early diastole hitting that stiff ventricle wall.
Okay, fatigue, breathlessness. What about fluid?
Yes, fluid retention is a big one. That backward pressure causes fluid to leak out. So you might see peripheral edema swelling in the ankles, legs, and pulmonary edema fluid in the lungs, which contributes significantly to the breathlessness. A really key clinical sign we look for is the jugular venous pressure, or JVP, in the neck. It's often elevated. And importantly, it can show these characteristic prominent X and Y descents in the waveform.
The XY descents. Can you explain those quickly?
Sure. The X descent reflects the pressure dropping in the atrium as it relaxes after contracting. The Y descent is the pressure drop as the tricuspid valve opens and blood rushes rapidly from the atrium into the ventricle at the start of diastole. In restrictive cardiomyopathy, that early diastolic filling can be very rapid, but then abruptly stops as the stiff ventricle reaches its limit. This accentuates that Y descent, making it look quite sharp and deep. It's sometimes called Kussmaul's sign if the JVP paradoxically rises with inspiration, though that's more classic for constriction.
Got it. Sharp Y descent. Anything else on examination?
You might also find hepatomegaly, an enlarged liver, due to that backed up pressure in the venous system, and sometimes ascites, which is fluid accumulating in the abdomen. And one more thing, atrial fibrillation, that irregular heartbeat, is really common, particularly in the idiopathic type. Maybe up to 75% of those patients might develop it.
Right, AF is common, so you suspect it based on symptoms and signs. What tests do you order to actually confirm the diagnosis and figure out the cause?
Okay, investigations. The echocardiogram, the heart ultrasound, is absolutely central. It lets us see the heart structure, measure chamber sizes, check the wall thickness, assess the systolic function. the squeeze, and crucially, evaluate the diastolic function, the relaxation and filling patterns. An ECG, electrocardiogram, is standard. It might show nonspecific abnormalities, low voltages sometimes, or evidence of atrial enlargement, conduction problems, or arrhythmias like AF cardiac MRI, or sometimes CT scans are increasingly important. MRI especially is fantastic.
Why is MRI so useful here?
Well, it gives incredibly detailed pictures. It can help characterize the heart tissue itself, looking for signs of infiltration like amyloid or inflammation in sarcoidosis or fibrosis scarring. And as mentioned, it's probably the best non-invasive test for differentiating restrictive cardiomyopathy from constrictive pericarditis because it images the pericardium so well too. It provides 3D views, quantifies volumes, and function accurately, detects scarring, fat infiltration. Really powerful.
Okay, echo, ECG, MRI. What else?
Often, the definitive diagnosis, especially if you suspect infiltration like amyloidosis, requires an endomyocardial biopsy. That involves taking tiny samples of heart muscle, usually from the right ventricle via a catheter. Then you look at it under the microscope. For amyloidosis, you'd look for that characteristic Congo red staining, which shows up with a specific kind of light.
The gold standard, biopsy. Any blood tests?
Yes, definitely. Routine bloods are needed: kidney function, electrolytes, liver function tests, which might be abnormal due to congestion, cardiac enzymes like troponin, which might be slightly elevated. And depending on the suspected cause, specific tests like iron studies for hemochromatosis or tests for amyloid proteins. Sometimes cardiac catheterization is still done. It directly measures the pressures inside the heart chambers and can show specific hemodynamic patterns characteristic of restriction. And there are newer, more advanced echocardiography techniques too, like speckle tracking or velocity vector imaging, that give even more detailed info about how the muscle itself is moving and deforming. But yeah, usually you start with the ECG, maybe a chest x-ray, which might show heart size or lung congestion, basic bloods, and then move quickly to echocardiography and often MRI and potentially biopsy, depending on the findings.
Okay, quite a workup. Once you have the diagnosis, how do you manage restrictive cardiomyopathy? What's the treatment approach?
Management is challenging, honestly. The main goals are really symptom relief, trying to improve quality of life, and managing any associated rhythm problems. A key point is that the underlying stiffness, the primary process in the heart muscle, often doesn't respond very well to medications aimed at, say, making a weak heart pump stronger. The focus shifts. If you can identify and treat an underlying cause, that's crucial. So specific treatments for amyloidosis if possible, or iron chelation therapy to remove excess iron in hemochromatosis.
Right, treat the cause if you can. What about general management for the heart symptoms?
For the heart failure symptoms, primarily the fluid overload, diuretics are the mainstay. Carefully used to reduce congestion without excessively lowering the filling pressures the stiff heart needs. ACE inhibitors might be used cautiously, but sometimes they can drop blood pressure too much in these patients. If there are dangerous ventricular arrhythmias, medications like amiodarone might be used, although they have side effects. For atrial fibrillation, anticoagulation blood thinners is usually vital to prevent strokes, unless there's a strong reason not to. And then you need to control the heart rate in AF, often with beta blockers or certain calcium channel blockers, the non-dihydropyridine type like verapamil or diltiazem.
What about devices, pacemakers, defibrillators?
Yes. If the condition affects the heart's electrical conduction system, causing slow heart rates, bradycardia, or heart block, then a pacemaker might be necessary. And in patients considered high risk for sudden cardiac death from ventricular arrhythmias, an implantable cardioverter defibrillator, an ICD, might be recommended. That device can shock the heart back to a normal rhythm if needed. And then, for very severe advanced cases, particularly in younger patients or children where the cause is often idiopathic, heart transplantation might be the only remaining option.
Right. Transplantation is the last resort. You mentioned children often have the idiopathic form.
Yes, interestingly, when restrictive cardiomyopathy occurs in children, it's quite often idiopathic, and unfortunately the prognosis can be poor, making transplantation a more frequently considered treatment strategy for them compared to adults with other causes.
So that leads into the prognosis. What is the general outlook for someone diagnosed with this?
It's really quite variable, and it heavily depends on that underlying cause. Generally speaking, patients whose restrictive cardiomyopathy is caused by infiltrative diseases like amyloidosis or conditions causing progressive fibrosis tend to have a worse prognosis. Amyloid-related restrictive cardiomyopathy, in particular, has historically had a fairly poor outlook. Treating cardiac amyloidosis is tough maris. Patients often don't tolerate standard heart failure drugs well, and even outcomes after heart transplants haven't always been as good as for other conditions.
Hmm. So amyloid is particularly challenging.
It has been. However, there's a bit of a positive note here. There have been some really significant advances recently in both diagnosing the specific types of amyloidosis earlier and more accurately, and also in developing targeted treatments for certain types. So while it's still serious, the prognosis for some forms of cardiac amyloidosis is definitely improving thanks to these new therapies. That's quite encouraging.
That is good news. And finally, what are the main complications people need to be aware of?
The major complications really stem from the underlying pathophysiology. So, progressive heart failure is a big one. Arrhythmias, both atrial, like AF, and ventricular, which carry the risk of sudden death. Because of potential sluggish blood flow in the enlarged atria, especially with AF, there's a significant risk of blood clots forming inside the heart. These can break off and travel, causing a stroke or blocking arteries elsewhere. And as mentioned, sadly, sudden cardiac death is a potential and devastating complication.
Okay, so wrapping this up then, if you had to give the key takeaway message about restrictive cardiomyopathy from our deep dive today, what would it be?
I think the core message is restrictive cardiomyopathy means a stiff heart muscle that struggles to fill properly, even if the squeeze is okay initially. Remember, the diverse causes infiltration like amyloid, storage diseases like hemochromatosis, sometimes unknown, and crucially, that underlying cause really dictates the management approach and significantly impacts the prognosis, the long-term outlook.
Perfectly put. A stiff heart, filling problems, and the cause is king. We really hope this focused discussion has helped you, our listener, build a solid framework for understanding this quite complex condition. Remember, this is a foundation. There's always more to learn and explore. If you are preparing for exams or just want to test your knowledge further, definitely check out the resources over at passtheSRA.com and freeESRA.com for more focused content and practice questions. It really makes you think, doesn't it? How vital that simple act of relaxing is for the heart, just as important as the squeeze and the profound challenges when that relaxation fails.